We have some incredible stories, light in the end of the tunnel, or they have a feeling they were really out of their body.
To make decisions where literally someone's life is on the line.
I really thrive on challenges, and you have arrhythmia. Boom. Your chances to survive are very, very low. By putting you on this machine, we can achieve almost 30% survival rate. The brain, once there is a damage, it's irreversible.
No head replacements yet, yeah?
It's not like in TV, give the heart a shock, and really the heart will restart.
Welcome to the Good Health Society podcast. Today, we are honored to have Dr. Daniel Robb from the General University Hospital in Prague. Všeobecná fakultní nemocnice, VFN. Dr. Robb is a leading interventional cardiologist and researcher, well known for his pioneering work in cardiac arrest and advanced mechanical support for heart function. He is one of the investigators of the Prague out-of-hospital cardiac arrest trial and registry, and his impactful research has gained widespread recognition in respected medical journals around the world. In addition to his research, Dr. Robb is deeply committed to education. He teaches at Charles University's first medical faculty and helps train medical professionals around Europe in life support techniques such as the Extracorporeal Life Support and extracorporeal membrane oxygenation. His influence reaches globally through his involvement with organizations like the European Resuscitation Council and the Extracorporeal Life Support organization, where he works on developing best practices and guidelines in advanced cardiac care. Today, we're excited to dive in to Dr. Robb's groundbreaking projects, his vision for cardiac resuscitation, and his dedication to advancing patient care through research and innovation. Please join me in welcoming Dr. Robb.
Hello, and thank you for such a nice introduction. It's a pleasure to be here and welcome in our hospital, in our catheterization laboratory. Honestly, I consider myself just a hardworking physician, and I'm just a piece of the puzzle of a very large working group here and also on the European level.
It's the Czech humbleness, yes.
Well, tell us about where we are, because this is a really beautiful building. We came in and we saw a nice statue in the courtyard. What's that all about?
Our hospital was founded by the Emperor Joseph II. He was Emperor of the Roman Empire, and he was also King of the Czech state. 250 years ago, he founded this hospital, and it was one of the first hospitals in Europe. And currently, the construction is still underway, as you can see outside of the building, because I made a real joke like many years ago, that if the king will be resurrected, he will be really surprised that the building hasn't changed a lot, but it's just a fun. Inside, the building is very modern, and we have all the equipment necessary for the most modern care.
It is impressive. This looks like Star Trek, at least to the lay eyes.
So the first question will be, what is it that you actually do here, and what motivated you in order to do it? And is there any fun story associated with that path being laid forward?
The members or the listeners would love to know, what is extracorporeal life support? What is this membrane oxygenation?
Let's start with the stuff. So, extracorporeal life support or extracorporeal membrane oxygenation is basically, I can say, is extracorporeal circuit. You take the blood from the vein. It can be inserted. Usually, we insert it through the femoral vein to the right atrium of the heart. So you suck out the blood to the system. In the machine, there is a pump, pumping the blood back to the body of the patient, and there is an oxygenator for changing the blood gases. So this is the extracorporeal circuit. So you can bypass your heart. So you can, for example, there are many fields where you can use it. You can use it for cardiac failure, respiratory failure, and there are differences. But what's done here is the bypassing the function of the heart. So if your heart is failing or if it stops, this machine is very powerful to regain the circulation. So we can achieve, even if your heart is still stopped, by putting you on this machine, we can restore the circulation and sometimes save your life.
It's fantastic.
And when would something like this be used?
When?
Yeah.
Okay, so the indications are, from the perspective of cardiology, and there are two main indications. It's cardiac arrest, if you have in-hospital or out-of-hospital cardiac arrest.
Heart attack, yeah?
Yeah, it's again.
This is
yes, it's important. So there are a variety of reasons why you can have cardiac arrest. The most common cause of cardiac arrest in our population is sudden heart attack, clot in your coronary artery. Your coronary artery will get obstructed, and you have arrhythmia. Boom, your heart will stop. You fall immediately. You lost consciousness, and then this is cardiac arrest. But of course, you can have different reasons for cardiac arrest. You can have pulmonary embolism, which can cause cardiac arrest. This is a clot in your pulmonary bed. You can have hypoxia. You can have suffocating. You can drowning. Yeah? And these all critical stuff can lead to a cardiac arrest.
Gotcha. So that is what you do, yes?
Yes.
Yes.
So basically, we do a lot of stuff, but our main aim of and the main aim of our research is the so-called extracorporeal cardiopulmonary resuscitation. So it means that to get it simple is to put people in cardiac arrest, so-called refractory cardiac arrest. So basically, people who are not responding to conventional resuscitation, massage and defibrillations. So if there is a failure of conventional resuscitation, your chances to survive are very, very low. After 10-15 minutes of conventional resuscitation failing, your survival rate is like 4%, sometimes even less. Mm-hmm. And with this technique in selected population, it's not for everyone, but with this technique in selected population, we can achieve almost 30% survival rate. Yeah. So still, of course, there is a very high burden and many deaths, but we can increase the survival rate a lot with this technique.
What led you to do the work that you do? What motivated you, and is there anything interesting associated with this?
Interesting story. I must be honest, there is no interesting story at all. At the end of my medical studies, I made a rational decision. I wasn't completely sure if I should go for cardiology, but first, I deemed cardiology to be extremely interesting field because it encompasses all the things in medicine, from prevention to diagnosis, very interesting differential diagnosis, to advanced technologies in imaging, echocardiography, computed tomography, MRI scans, up to acute intensive care and interventional cardiology, doing procedures when stakes are really high. And the second reason is that I really thrive on challenges. So I believed, like more than 10 years ago, that this field of medicine can be really interesting for me. And it wasn't passion in the beginning, but after the first year of my fellowship here, I witnessed some really super interesting cases and life-saving moments. This ECPR, like the extracorporeal cardiopulmonary resuscitation, and like 9 years ago, it was like a true passion for me. It has started and it's still passion for me.
I'm personally very fascinated by your line of work because you are literally in the moment of life and death, and it's a lot of the time in your hands. So I know that's something you're used to, it's something you do on a daily basis, so you may take it for granted, but for us mere mortals who do not experience such things, it's a really, really big deal, and obviously it impacts society greatly, and so I'm really grateful to be in your presence and to learn from someone like you. But what's really interesting to me is high stakes decision making. I mean, you have to make decisions where literally someone's life is on the line. Can you walk us through what that's like mentally, emotionally, inside? Obviously, I imagine you've become used to it to some extent, but nevertheless, it must be quite an intense experience.
Yeah, it's a nice question. You are completely right that you have to get used to it. So it takes many years to get used to it. And I believe that you must try to get it under control in your head. So when I deal with such situations, when there is a dying or crashing patient in front of me, I try to really think in a logic way. So first, you need to know perfectly what you should do. So you should have a great knowledge about indications, contraindications of the procedure, about the technical aspects of the procedure, to start at least feel confident. Second thing is that you must have great knowledge about the characteristics of the patient, which are associated with some risk factors. So if you have any time, you should study the patient characteristics, which can help you in any case. And then I personally believe that it's also important to have at least quick visualization of the situation. So if you have at least 1 minute, you should quickly visualize the situation in your head, how it should ideally go, and then what's the worst case scenario. So you are also prepared for the worst case scenario. Then I believe we all are here work in a team. So you are never alone for such situations. Even if you are a leading physician here or in the ICU, you still have experienced nurses. You can call colleagues. Yeah? So you are never alone. And I believe that it's always associated with stress. Even after many years, you will feel stress. But I found it important to convert the shaking negative stress into focus. And I believe it can be done. Of course, it took a lot of years, but you can get into some state of focus where you really don't feel nervous at all, and you feel really comfortable.
That's a really interesting point, that you're actually harnessing the stress to turn it into focus. So you're taking something that could otherwise take someone apart, and you're bringing it into a sort of a, say, constructive mode.
How long does it take to be able to do that? This level of expertise.
Yes, I think it's really individual. Yeah.
Ballpark figure, years. I know we're talking years. Yes.
Years. Yeah,
for you, how long did it take?
So basically, the fellowship for the general cardiology, it takes at least 5 years if you are good. And then after these 5 years, of course, I specialized almost after the first 2 years, because my boss was really kind to me, and he told me if you really want to do this stuff, come with us. So I was part of the ICU team. I have started to be part of the ICU team 9 years ago, and I have done with my teacher and mentor hundreds of cases in such a critical situation. And then finally, after let's say 5 years, I was able to do even case on myself. Yeah? So it takes years of practice and training. And you of course, the role of teacher and mentor in these situations is important. And I try to also right now to be also teacher for younger fellows and colleagues.
Is there any specific process that you go through after such an event where you're really, really focused, you've saved a life, and then now it's over, but there must be stress remaining in your body?
Yeah, so there should be always some feedback. Yeah. Some routine on the ICU or here in the cath lab if there is some tough case, no matter how it ends, whether it was a good case, bad case. So if we have any time, we try to sit at ICU, and we made a regular routine that every Tuesday we try to debrief these cases, the most challenging case. If we have time, we try to debrief. It's important for the team, yeah. Especially I would say for the nurses, yeah.
So it sounds like learning and, in a way, therapy.
Yes.
Okay.
But of course, after all the cases, you should be able to reflect on yourself, your performance. Of course, you will have good and also not optimal performance, and you should be able to admit it to yourself and try to learn from your mistakes, because we are not perfect and we make mistakes. So,
just like in sports.
Yeah, it's very similar to sport, I would say.
And is there anything that people might not realize about the life of a cardiologist? Is there something that is not so commonly noticed, or?
It's not like in TV movie. Yeah, or TV series. I think there are very different ideas about how our work can look like, and honestly, it's there. Of course, there is a lot of routine stuff. Yeah, paperwork always. Yeah. But then maybe a lot of night shifts, night calls, and a lot of stress. There are some really exhausting situations with patients and families, yeah. But in the end, it's really rewarding field. Yeah.
Yeah, that's one of the ironies that I find about what you do is that, when I see you come to the gym sometimes after work, you're tired, you haven't slept, your shift and your light cycle is off, and, it kind of feels like you're sacrificing your own health to some extent in order to save lives, and that's something that I really, really respect, but it's something that I wish that people like you would have more room to recover.
I would say that it gives you energy to help other people and to take care of other people, not to focus on yourself. And I found it a very good way how to live your life. That, of course, I would appreciate if I would have more time for my family. Yeah.
Does the novelty ever wear off? Because you might have somebody who's close to death, and if you manage to help this person, there's this big contrast, right? It's work you've done that has resulted in a benefit. And I imagine for the viewers, for myself, this is something amazing, right? Because it's like there is a reward that you get to see. There's a whole process. And for you, that is still rewarding?
Yes,
yeah.
It is. It is.
That's great.
It's a real joy to see the person who was facing death, to see this person going back home, and we developed a follow-up system, and I believe this is very important, and it's not common in all systems. So we also follow these people with the most severe critical illness, let's say a refractory cardiac arrest. So these people are, for example, after 60 minutes of conventional CPR failing, they survive, and then they have routine checkup at our outpatient department, and we manage to have some time to see these people, and it's really important to have this feedback. And there are, of course, good things and bad things. Some people are still struggling, but it's really important for the acute care physician to have the feedback how the people are improving and getting back to life. I think it's really rewarding, because if you see only what's happening in the ICU or here in the catheterization laboratory, it's just a very small part of the story. Yeah. So I think, personally, to me, it helps me to deal with many things and many questions in my head about our work, and I believe it's also very important for all healthcare people here taking care of the patients.
Good. Are there any advancements, recent ones, with respect to technology that have improved the ability for you to care for people in cardiac care?
So during the last one decade, there was a great development of structural interventions, especially in the field of heart valve interventions. So currently we are able, in many patients and in the critically ill patients and older patients, we are able to fix the heart valve dysfunction in most of the heart valve dysfunctions by minimally invasive procedures through the vascular access in the groin. So this is one, for example, the big advancement in the field where we can see a real difference, because like 20, 30 years ago, the only option for these patients was open heart surgery with a long time in general anesthesia. So of course, for a very critically ill patients, it was sometimes impossible to survive such situation. So right now there is a big improvement in this. And in my field of acute intensive care, I would say that in this field, the story of the ECPR, the extracorporeal cardiopulmonary resuscitation, is quite a new method. We have started this program in 2012. Systematically, we published the randomized controlled trial 2 years ago, and it was one of the first trials in this field, and it's still the largest trial in the world done in this field. So it was really great to be part of this story, and it's still like there is an ongoing super interesting research in this field, even in the animal labs, translation science and clinical science. Including all the stuff about the extracorporeal circuits, how to make it more compatible to your body, how to increase the rate of survival, how to improve the neurological function of the survivors. So it's extremely interesting field.
Is there anything that you're looking forward to in the future? Some sci-fi stuff like little robots doing the surgery or cleaning up the blood vessel.
Okay.
Nanotechnology.
Of course, there are researchers trying to find out how to get the blood cholesterol out of your vessels. Yeah, it's far away, I think, from the reality. But in the future, we will be, I think, free of. I will have many free days if it can happen. Okay. That you will have such, if you have such a therapy. But what I foresee in the future is a real advancement in the field of cardiac arrest research. I believe that we will be able to find out how to resuscitate more patients with a special circuits which will alleviate the brain and body injury after prolonged cardiopulmonary resuscitation. Because the most common reason why patient wouldn't survive such a critical event is the brain damage. Mm-hmm. And currently there is a really interesting ongoing research how to preserve the brain function even after a prolonged CPR. Okay. Yeah. I believe in the future, I really believe it, that we will have a special circuits where we can insert just the cannulas into the groin, femoral vein, femoral artery, put the patient on the circuit, and the survival will be higher.
So you're looking forward to keeping the brain alive for longer when the heart is not working, and that technology might help.
But the heart will usually recover.
Okay, and then bring the heart back in line to pump the blood to the brain.
Usually, like in most of these cases, the heart is not a problem. We can fix it. Yeah. And of course, there is a majority of patients who really need heart transplant. So we can manage it, but not the brain. The brain, once there is a damage, it's irreversible. Yeah. So this is the main issue for resuscitation and.
Maybe that's why we have the skull protecting that vital piece of the puzzle.
Darn, that social media post was a deep fake. Replacing the head.
You can't, no head replacements yet, yeah?
Not yet.
Yeah, it's far away from the reality. Yeah.
Have you noticed any changes in the population, like demographic-wise or maybe lifestyle-wise over the last decade or so? And has that perhaps, if that's the case, has it affected your process in any way?
So there are studies showing that there is a decrease in the incidence of heart attacks in Europe and even in the Czech Republic. Mm-hmm. So it's a great story because it's a combination of factors. It's a combination of, I think, that the population is more aware about healthy lifestyle. The system is improved from the routine work of preventive medicine to our work. So we are basically lowering down the rates of heart attack and we are increasing the survival. So based on the population level, there is a increased awareness of such stuff. There is an ongoing fight against smoking. It's really important. There was a ban of smoking in the pubs and in some public places. It helps also. And on the population level, let's talk about population level. What we see, of course, is change in demographics. The population is getting older, and it's a big challenge for all healthcare systems in Europe. So I think these are two main things I can see on the population level. Of course, there is a great deal with obesity. There is a very big interest in the new medicine for obesity, and it's also, I would say, the story on the population level, very interesting one.
Now, we'll get into a little bit of preventative care. Basically, what can the common person do not to end up on this table? Take it away, and then we'll follow up with some questions.
Okay, I have to disclose that I'm not an expert on preventive care. Yeah.
Which is actually a very good line to have, because people will often put a certain authority to someone like yourself and imagine, since you've gotten to where you are, you must know everything else into every direction and below. Yeah. So,
unfortunately, even outside of cardiology, but believe me, the field of medicine is currently very focused on specific topics. So I can deem myself to be expert on extracorporeal cardiopulmonary resuscitation, but I don't deem myself expert to some other stuff in cardiology. But let's go back to preventive stuff. Yeah. So first, stop smoking and never start smoking. and if you smoke, try to quit it. And if you are not able to quit it, then try to find medical help. I think it's critically important because many of our patients are active cigarette smokers, and there is still a high percentage of our population still smoking. The second stuff, of course, regular physical exercise. And it's not evidence-based, but I believe that everyone should try to find at least 5 to 10 minutes daily to get some exercise. I think there is no excuse, except of some illness, that you will not find for yourself 5 to 10 minutes daily to do some exercise. And I think it really helps not only to your physical but also mental health. The third thing I believe is important is diet, of course. But I personally struggle with diet myself. So from the field of evidence, like we take it by evidence-based medicine, I know that currently the most well-studied and like hard, healthy diet is a Mediterranean diet. So diet rich on omega-3 fatty acids, olive oil, fatty fish, fresh vegetable, fresh fruits, some nuts. However, I tried myself to follow this diet, and it can be quite easy. If you are on your holidays next to the sea in Italy or Greece, but it's very hard to follow this diet if you are in the Czech Republic, in Central Europe, in Prague.
It can be a logistical issue.
Yeah.
Maybe the sunshine's got something to do with it too.
Yeah, exactly. This reminds me of one important point, that there is no one-size-fits-all approach.
Sure.
There is no one-size-fits-all, not even in our ECPR stuff here, and not even in these recommendations. So you have to find your way, and if you have any possibility to ask someone for advice, it's great. And except of physical activity, diet, and some weight control, I believe it's also stress management, because today we live in a, I would say, very demanding era of informative technologies. So you are all the day, basically, immediately on the phone, on emails. So it's really important to calm your mind down and try to get rid of the stress.
With that in mind, yeah, well, we're very reactive to information, and that information could be positive or negative. It could be something that is constructive or something that we cannot do anything about. And a lot of people do struggle with dealing with such inputs. So mental hygiene, I guess, is the bottom line here. But for a person, one of our listeners who wants to look at, let's say, and assess themselves, what are some key vitals and tests that could, let's say, extrapolate some key information for them to assess their own health and make some lifestyle changes? What would be your top few tests that you would recommend for people? Okay,
so key vitals are definitely blood pressure. So you should have your blood pressure checked. Then heart rate, of course. It's individual again, but the heart rate is important. Then weight, there is a debate about whether weight or body mass index, but you should be aware of your weight. I would divide the population into low risk, intermediate risk, and high risk from the perspective of cardiovascular events. So if you are low risk, it means that you are usually young, completely healthy, you have no symptoms, no problems, you have no family history of severe heart attacks in your father, mother in a young age. So if you are healthy, everything you need to do is just a regular checkup every, let's say, 5 years to visit your family physician, and that's fine. But if you have already some risk factors, meaning you have a genetic risk based on your family history, or you have you have a high blood pressure, or you have a high blood cholesterol, or you are under continuous stress, then you should be more aware about these things, and you should have a regular, let's say, every year checkup to your family doctor. And if he realizes there is something going on, he will send you to a specialist.
Are there any habits that you would recommend for heart health? Very, very basic habits for regular population. Just a couple of simple things they can do.
Okay, I will repeat myself. So never smoke.
So don't do.
Yeah,
What
yeah.
can they do?
Like from my perspective, I find myself a very powerful tool, the short, quick exercises. Even if you are short on time, to find yourself at least 10 minutes to get some regular exercise, it really helps. And
What kind of exercise is this? Do you run? Do you
Good
do
question.
push-up?
yeah,
Do you do a sit-up?
yeah, I think it's again very individual. For me, I find myself, let's say push-ups, great. Some resistance training, very short one, or I also love stretch exercises, so some short, like a yoga-like exercise. Yeah.
What's the feeling that you hope to get after having done those exercises? Do you hope to get sweaty? Do you hope to get out of breath? Or do you hope to feel a little bit stimulated, buzzing?
Just stimulated.
Stimulated,
Yeah.
just a little bump up,
Yeah.
but not exhausted.
No,
That's good.
not exhausted. No sweating. It's just feel better. Yeah.
So not creating extra stress, but exposing yourself to enough intensity, I suppose, in order to just drive positive adaptation, right? My assumption as a trainer is that you want to peak your heart rate, or at least increase your heart rate somewhat, and allow it to drop. And that dropping is your body's, let's say, reaction to the stressor, right? So that's
My assumption as a lazy person is what you're doing. Just a little bump up.
Yeah.
I wouldn't say lazy. I try to be strategic with this because I've seen many people burn out.
Yeah.
And always people say, what more can I do? It's probably not more that you need in today's world.
And I believe in habit really. You have to make it a regular. And for me, with my job, it would be very hard to have a 1 hour training every week. And Paul knows it because I visit him, and it's very hard for me to sometimes get to see the Paul. Even, for example, I have 3 weeks off. Yeah? So I realize these 5 to 10 minutes are critically important for me because I can find them in my busy day, every day. And of course, Paul is helping me with it. How I found, like based on the Paul advice, I found myself what's the right thing to do in these 5 to 10 minutes.
Great.
I believe he has a weightlifting bar back here somewhere.
Yeah,
Chin-ups on that thing there.
It's not here, but it's in my room. Yeah, in my.
I imagine when you consult your patients, you also work off of some pattern recognition, meaning if a person walks in with this weight, if they are swollen or not, then this is a pattern that you recognize. Has this pattern changed over the last years? Are people presenting with different things than they used to?
Honestly, I don't see such change in my population. There are some studies showing that in children population, unfortunately, there is a big trouble with obesity and low physical activity. Yeah. So, but I'm not a pediatrician, so I'm not personally aware of it. But from my perspective, my regular patient is still the same as 5 years ago. There is no big change.
I have a really big topic that's really heavily loaded, but I would like to keep it really simple, and I'd just like your input on it. I think maybe a segue into this would be my beginning as a personal trainer in 1999. So I did the courses, and I learned about the food pyramid at the time, and I judiciously applied all of the principles, and my clients weren't getting much results. And then there was the crazy guy in the back of the room having them eat steak and do high intensity exercise, and they were dropping weight and feeling great. And I thought there's something wrong with our paradigm. Nowadays, there's quite a lot of conversation about cholesterol, what's good, what's bad, and of course the classic view is that cholesterol is a bad sign, especially when it goes up to past a certain point. But now you have this group of, let's say, researchers, doctors, trainers, and so on, who are really pushing this idea of nuance, meaning that it's not just the cholesterol, but there's also other parameters that we should be looking at, such as triglyceride and HDL ratio, inflammation in the body, and so on. And what they're arguing for is this idea that if you have an increased cholesterol, but all of the other parameters are fine and in balance, that maybe it's not such a big problem. That interests me because you and I obviously see very different populations. I get to see people who are very motivated, or not, but either way, they're looking to make a positive change, and they're embarking on very good habit. They're trying to exercise, they're trying to eat well, they're trying to get into better shape. And whereas you may see people downstream that already have problems when they show up here. So that means that our experience is going to be vastly different in terms of what we perceive works. That's not to say that anybody has any ultimate truth, but what I'm curious about, and sincerely curious, is that sometimes the things that we see are counterintuitive. You might have a person with high cholesterol, but they look and feel great. And for us as trainers, that's really confusing because we'd like to give people standard advice, but sometimes it doesn't match our experience and what we see. Now, somebody feeling great and being really strong obviously doesn't mean anything long term. It just means that they're doing well right now and they could be building up a problem. I suppose that would be the sort of medical view of the situation. So with all of that said, I'd just like to hear your input on in general terms.
It's a very complex and difficult question, and it has been discussed in all cardiology conferences for like many hours. But you are right that blood cholesterol is just part of the story, definitely. And I think the medical community will agree. The second important thing, that all cholesterol is not created equal. As you already mentioned, there are good and bad particles, but there is ongoing research in it. So we know that LDL, there is a large body of evidence showing that LDL cholesterol is not good for your vessel. Definitely, it's very bad for your vessel, but there are other particles which are maybe even more important. And of course, some of your blood cholesterol level is determined by your genetics. So you can be very lucky. And based on your genetics, proteins in your body and receptors you inherited from your parents, you can have extremely low blood cholesterol even if you eat trash food. Yeah. Mm-hmm. On the other side, you can really try to live healthy life, but you are under constant stress, you work a lot, and you will always have a high blood cholesterol. So it's a very complex issue, and you are right that for young people, this is not the most important thing. I believe just some measurement of total blood cholesterol or LDL. But again, as a medical doctor, I must stress that there is like an incredible body of evidence from all over the world and very rigorous trials showing lowering of LDL cholesterol is beneficial for your health. First and always, you have to do lifestyle changes. So before you think about any medical therapy, you have to live healthier, you should eat better, you should get to the regular physical exercise, and then it's based on your discussion with your physician, based on your risk, as I already mentioned, like low risk, intermediate, high risk. We have a special calculators based on the population level. We can estimate your cardiovascular risk in the next 10 years. Based on this, we can make some qualified advice for you whether you should take some pills for lowering blood cholesterol level or not. So this is, I would say, for people in primary prevention, otherwise healthy people, but in secondary prevention, meaning that you already had some cardiovascular event, heart attack, stroke, then the combination of lifestyle and medical therapy is crucial. And there is, again, I'm extremely confident in the evidence-based medicine that in this population, statin therapy and the blood lowering cholesterol therapy works very well, and it has saved millions of lives all over the world.
Now, if somebody does end up taking a statin, as advised by their doctor, is there something that they should pay attention to? Because there are different types of these medications, and sometimes within a few months a person might feel unwell. There may be some side effects, and the person might need to go back to their doctor and have this reevaluated and maybe take a different one. Is there something that the person should pay attention to when taking a statin? And if they do see this, they should speak to the doctor so that they can maybe take a different one.
Okay, always, yeah. Very good question. So you should be aware that, of course, the main well-known adverse event of statins or side effect is muscle pain. But there are like big differences of reporting muscle pain and then so-called myopathy, the medically diagnosed problem. Yeah. So the rate of myopathy or even some really severe muscle damage from statins based on the lab tests is very, very, very low. Yeah. Usually very few people will get serious health issues, but the people should be aware if they have any muscle pain, they should refer it to the physician. And if you refer it yearly, don't worry, the statins, you just stop it using it, and usually, in most cases, you will feel better in a few weeks. Yeah.
Which muscles in particular should the people watch out for?
It's usually patients are reporting to me diffuse muscle weakness or pain, usually diffuse in your legs, arms, all over the body. Of course, it's side effect of many pills, including statins,
Sure.
the gastrointestinal issue. Yeah.
Okay.
So many patients are also reporting to me constipation. Yeah. After using statins. So gastrointestinal issue are sometimes also referred to me after I prescribe statins. But otherwise, I would say that this medication is very, very safe. And the only thing patients should be really aware of, if you have muscle pain, just refer it to your physician. We can do lab tests to check the creatine kinase levels. These are the enzymes. In case there is any myopathy or the lysis of your muscles because of the statin therapy, we will realize it so we can definitely confirm or exclude it. And in the case it's true that you are not tolerating statin therapy, you already mentioned, in the current era we have many other possibilities and many different type of pills and medication. However, no other medication has such a good evidence like statins. So the body of evidence and the effect of statins is enormous, and it also includes the anti-inflammatory properties, not only lowering LDL cholesterol, which is important.
This is actually something I wanted you to speak to, because I think there are other benefits of statins that people may not be aware of, right? People, especially in our industry, who criticize statins, they will refer to relatively poor, let's say, endpoints when you look through the studies. But that's not the only benefit. Lowering LDL cholesterol and the endpoints are not the only benefits that statins espouse. So you mentioned inflammation. That's interesting. So it lowers inflammation in the blood vessels, or?
It lowers even like a high sensitive CRP. There is, for example, my friend and colleague, Professor Kovárník, he did a nice study of patients after heart attack. They had a buildup in their plaques in the coronary arteries. So he examined it by the intravascular ultrasound during these procedures we do here, and then he asked them in the study to perform a follow-up after several months on a very high intensity statin therapy, and he was able to show a plaque regression. Yeah. A regression of the total plaque burden by intravascular ultrasound. So basically what statins are providing to your vascular health, if you already have atherosclerotic disease, atherosclerotic plaque burden in your vessel, it can stabilize the plaque and it will lower the inflammation, because the buildup of the plaque in your vessel, it's a very complex process, but basically your wall will suck in the blood cholesterol if it's permeable. And the additional benefit of statin is it's just not LDL lowering drug, and there are just LDL lowering drugs, but statins can also decrease the inflammation in your vessel wall, because if you have there macrophages and other inflammatory cells in your vessel wall, then the permeability is higher and your vessel wall will suck in the blood cholesterol. So the effect of statin is really complex. It really can stabilize the plaques, and it has been really proved by very meticulously done research, even by my colleagues, which I super trust. So I know there is quite a criticism of statin therapy generally. But in this way, I believe in evidence-based medicine and the effect of statins. But it's also true, sorry, the last sentence, it's also true that of course if you give statins to people after heart attack, the benefit is huge. If you will give statin to a 35 years healthy man with no risk factors, just a high LDL cholesterol, then the evidence is not so strong, and of course the benefit is much smaller compared to the guy who had heart attack. And there is an ongoing discussion, where is the risk-benefit ratio, which is a fine balance, but there will be always discussion about this. Even me personally, I can admit I have high LDL cholesterol, so I was thinking about taking statins, and I'm not sure in my age, but maybe like for the future, of course it would be, I believe it would be beneficial. I will take statins regularly.
That's a really great nuanced answer. I'm really happy for that because it really addresses this concern when people criticize, the endpoints not being lowered as much. Maybe it's because some of the population is over-medicated and they don't need it. But in the case of the population that does need it, it is highly beneficial. So that's parsing out the nuance. That's really great. I appreciate that.
And there is definitely no one-size-fits-all approach, because again, there are people and there are nice studies showing that there are some people with quite a high LDL cholesterol levels, and still they do not present severe atherosclerotic disease, even if they are very old or their age is high. And then there are people with a normal blood cholesterol level, and they have very severe atherosclerotic disease. So the LDL is just part of the story, and the permeability of your vessel wall for the cholesterol is a different story of inflammation of your immune system and everything else. And there is still ongoing research to understand this. But I believe we are getting to the truth. I have been in this field 6 years of medicine, more than 10 years of clinical practice, over the 16 years, and the evidence is still improving. So I believe the evidence is better and better. Yeah.
So the more we know, the less we know, right?
Yeah, exactly.
The further you can see,
Yeah.
the further you are from the start point. So to sum it up, cholesterol plays a significant role, so does inflammation. A statin can both manage the cholesterol and the inflammation. So if you can stop the damage somehow, if you can reduce the inflammation, you will also benefit. And there are a number of things that can reduce inflammation. Just off the top of my head, something along the lines of curcumin, some nattokinase. Nattokinase I'll mention, and then I'll ask you a question. I'll share a story. Is that I see a gentleman, and he's a executions lawyer. It's a very stressful job, and he read somewhere a study that nattokinase can help with his blood pressure, and he was already taking blood pressure medication, and he stopped taking his blood pressure medication and started taking nattokinase, and he claims that it helped him to lower his blood pressure better than the medication. I don't suggest this to anybody without consulting with their doctor, but it's just a story. An anecdotal story. And you can also play into this idea of like, what do you believe will work, right? I like to think that, many people say to me that they already feel better once they have made the appointment. Well, there is evidence that people get better on the way to the doctor because they believe they're going to be helped, right? This is the innate ability to heal something. Another analogy I will also use is that if we have a surgery on our arm because it was cut, and the person says, the doctor will give stitches, right? Did the doctor cure the surgery? No. You still have to go home and eat the right food, get enough sleep in order for the body to fix itself. So we have to be careful, I think, where we give the credit. And I've heard it come from you already. You're in a humble way. You try to stay away from being put up on a pedestal, and that's probably a mechanism for you to protect yourself from people calling you a God or giving you more credit, because this is probably not a place you want to be. But what I want to emphasize is the body's ability to heal itself once it's given the right circumstances. Now, to my actual question, what do you think about omega-3s? Because I don't remember anybody saying to me, I'm taking omega-3 and I actually feel better. But I have seen people feel better once they stop taking the omega-3, and this is regarding the heart fibrillations. I would say about four. I can name 4 people off the top of my head that I've seen who had heart fibrillations and they stopped taking omega-3 and it went away. And I know that there is some evidence, which is quite recent, which does suggest this. So we're probably another situation of it depends. But what's your take?
Yeah, you are right that, again, this is very individual and there is no one size fits all. So there are studies, very rigorous randomized controlled trials, which showed in the population of very high risk population after heart attack that a high dose of omega-3 fatty acid supplements can lower the future cardiovascular risk, meaning lowering the risk of atherosclerotic events, because omega-3 acids, fatty acids, should lower your triglyceride level, improve your lipid profile, and they may exert some anti-inflammatory properties. And again, if you are otherwise healthy person, you have no risk factors, I don't see any reason why you should take supplements, but you should try to find your way to healthy diet, which should be, there is general recommendation, rich, let's say, on omega-3 fatty acids, meaning some nice fatty fish, once, maximum 2 times per week, yeah.
So some sardines versus the pill.
Yeah, exactly.
There we go.
That makes sense in light of, talking about oxidation and products being rancid. If we're talking about a supplement, that bottle may already have been exposed to sun. It may have oxidized, right? And that all of a sudden the same product becomes not so good for us. So I imagine the sardines would be much better in that way. So I think the story you made about the execution lawyer, it is a nice segue into talking about psychosomatics and stress. There are periods periods in our life where we can fall into what I call the body lying to us, right? So I've been through a very stressful period where you had helped me, and I will never ever believe any symptom again unless it's quantified, because the body can lie to us, and it can set off alarms that might be unnecessary. And we might go down a rabbit hole of, looking at research and trying to help ourselves and making the situation worse. And this is something that I often see with clients, especially A-type personalities. People who are very busy, expect a lot of themselves. They have a lot of responsibility. They sacrifice their own rest or their own nutrition or what have you, just like yourself or anyone else who's really trying to help the world around them, right? A lot of our clients are CEOs. They'll come in and suddenly you find out they're leaders, but they're having anxiety, they're having panic attacks, and they're getting, amongst others, cardiovascular symptoms. So I guess what I want to ask you is, how do you, as an experienced cardiologist, differentiate, when you see a client, how do you differentiate what you would consider to be more of a psychosomatic nature and what you would consider to be more of a, for lack of a better term, a plumbing issue? Let's say somebody's blood pressure has gone up. We don't know yet. Is that because they actually have heart disease, or is that because they're really stressed? That must be a very difficult distinction to make in your profession, because I imagine a lot of people show up discombobulated.
It's a very good question, and again, very difficult question. We deal with this every day. I would say that from my perspective, after many years dealing with patients with both mental illness and real plumbing issues, there is, I must stress the importance of understanding the patient and to have a good conversation with the patient. I think this will always help, not just the medical history, but to talk with the patient about his life. But the real problem is to have a time for it. Yeah? So to sit down with the patient and to talk with him. Then, of course, you can see these nuances, like whether he has a lot of stress in his life, what's his sleep, whether he is sweating, whether he has some personal issues, and it can be connected to the symptoms. But, of course, for us as a medical professionals, if there is any patient who complains of chest pain or dyspnea or palpitations, it's always important, always, to rule out the real physical problem. So even if there is a very young lady, and myself, I deemed her to be healthy and very stressed, anxious, and I believe it must be stress-related problem, I should perform basic medical examination, because I know all of us, like even me, we can be wrong with this assumption, because sometimes these problems between the mental health and physical health, they can be unfortunately somehow interconnected. And then you can't tell what was the egg and what was the chicken, but sometimes you can have a real stress because you started to have a real troubles, palpitations. I have seen people who had many examinations by cardiologists because they were complaining of intermittent palpitations. And they finally, after 10, 15 years, when they came finally in the period when they still feel the palpitations, we are able to detect the arrhythmia. Yeah. So there was some arrhythmia. Maybe it wasn't life-threatening, it was usually benign arrhythmia, but they were right, yeah, and they were anxious because it was a real arrhythmia in their heart. So it's really important to exclude these stuff. So to visit your family physician, and if he thinks it's a good idea to have a checkup with a specialist, so we will do the examination, and then based on at least basic examination, including the blood pressure, heart rate, ECG, I can tell that it's probably mental health issue or stress-related issue. So I try to recommend some basic stuff about the mental health. And of course, it would be great if I can refer these patients to a psychologist, but of course, these guys, they are incredibly overwhelmed by routine work or the work with the severely sick people. So it's not the thing we can do in real clinical practice. So I just try to advise these patients and try to tell them that we haven't found anything really important, but honestly, there is no 100% confidence. Yeah, even after you do a proper examination according to all the guidelines, there is still nothing like you are 100% sure that this patient will be healthy in 1 year. So there is always a room for some I would say that we are never sure. We can just try to exclude that it's not a plumbing issue or physical problem, and that's what we are doing every day, and try to differentiate it, but it's never 100% like we are really sure about it.
So you touched up on a very good point, is that there's an overwhelmed system which doesn't allow for this interdisciplinary approach which will tick the different drivers to a possible problem. Now, how do we fix that? Because you said maybe a psychiatrist needs to be implemented. Maybe the person needs to go and exercise under guidance of a physiotherapist. Do you have any suggestion or idea, right? Maybe this is a problem with technology that can be addressed with this. If there is something that you could have in order to improve the interdisciplinary approach, what would it be?
Yeah, if I would have such an idea, I would be probably billionaire. Yeah, but yeah, very good question again. I believe in the future, I can foresee that the use of IT technologies and artificial intelligence can really help us in this way. Yeah?
Which department would you like to be helped? The psychology or the movement or the nutrition?
All the departments. For example, some shared platform here in the Czech Republic, and there is a great development of these platforms, but not in the Czech Republic yet, that you can share all the information about patient health in one central platform. Yeah, and I think it will be of great benefit for patients and for healthcare providers if I will be available to get all the information in one platform. Just click on the internet and see the patient data and the patient history, because this information will give you a real benefit, and you can really get a lot of information from this. However, of course, there is a struggle with patient data protection, and it's of course super costly. So these systems in the future, I think, can really ease our way and find the right path for the patient. But it's not going to happen here in the next, I would say, decade.
Yeah. It reminds me of a hypochondriac friend of mine who talks about going to the spa. In other words, checking into the hospital, getting the tests to make sure he's okay. I suppose this kind of system would prevent that, or at least point him into the right department.
So until such systems are in place where an interdisciplinary approach that is really competent is in place, what can the common person do? They should maybe just recognize the fact that there are many reasons for their problem. Yeah. And go back to your suggestions of don't smoke, exercise.
Always.
I guess that is the interdisciplinary
basics,
approach.
And if you have symptoms, please visit your family physician and talk.
I suppose a really important takeaway is that, you know, we have the psycho and soma and they affect one another. We have this chicken and egg situation. So it could be that the stress of a diagnosis puts somebody into a rabbit hole, so to speak. And it could be the inverse.
Yeah, exactly. But first we need to exclude the real physical problems, and then we can talk about the mental health issue from my perspective, because unfortunately I have seen missed cases. And these are always tragic cases. Yeah. Young people who are deemed by other doctors or other hospitals just anxious, so they were sent home and they got here in the table with a heart attack or even cardiac arrest. Yeah. So these are rare cases, but it can happen.
I could imagine that, especially with a very busy healthcare system, when someone presents and they look absolutely fine, that they're not in a, let's say, endangered category, that could be problematic. You know that famous picture of that Polish heart surgeon after like 2 or 3 days? He's sitting on the ground, all the cables everywhere. He didn't sleep for 2 days. It looks like he wants to light a cigarette, and he just saved somebody's life.
No, I remember moments when I really fell asleep after the case, but never during the case, because when you are here, it's the adrenaline is so high, you will never fall asleep. So there are funny photos, like when they took photos of me when I was really sleeping, even in the ICU box. But after the case was saved, so and the patient life was stabilized. We have some incredible stories of saved lives after even 100 minutes of resuscitation, meaning that these patients were basically resuscitated for 100 minutes without success, and then we put them on the extracorporeal circuit. And they basically woke up after several days, and they went back to life, to a normal life, which is, I think, really amazing, something I have never imagined I can be part of it. And well, after 10 years of doing this, I really think it's normalized. Yeah, as you perfectly mentioned, it's normalized.
How about the people themselves? You know, when they come out of such an experience, I mean, for you, it's a daily activity. For them, it's a life-changing moment. Has there been anything profound that one of these people has said coming out of such an event? You know, maybe
I saw
thanking
the light,
you.
but
I saw the light. I saw
it.
God. I don't know. Jesus came to me, or something, or I'm going to be a completely different person as of today. You know, and I'm going to stop smoking and, you know, do this and this and this.
We have been doing research in it. And there is a questionnaire for these people who really survived this prolonged cardiac arrest about these issues, like light in the end of the tunnel. And some of these people really experienced these feelings, or they have a feeling that they were really out of their body. Yeah, so some, like I would say 20 to 30% of people surviving cardiac arrest are experiencing these feelings. But there is, we haven't published the results of this research yet, so I should keep it a little bit confidential. And I hope we will publish it, because there are not so many good evidence about it. But definitely there are people and we don't know what's the reason behind these stories. It can be that during the resuscitation there is a change in the brain function. So it can be explained by the change in your function of the brain, but we don't know. And unfortunately, we don't have any good how to measure the brain during cardiac arrest or even after cardiac arrest. We have, and it's an ongoing field of research. We have done here research how to monitor the brain after cardiac arrest. So there are many things like electroencephalography. We do electroencephalography. We do evoke potentials. We do CT scans, MRI scans. All these things are good, but they are far away from what we will need to really look into the brain, to the neurons, and to see what's going inside of your head. So again, it's very interesting, and maybe in 50 years we will have completely different idea what's going on. And there are really interesting stories from the patients, but we don't know whether it's just a brain change or whether there is something more.
Cool.
We look forward to that. That's a teaser.
I got a question. As one of my patients, he's going in to fix his fibrillation in his heart. And what they're going to do, according to his explanation to me, is they're going to turn it off and turn it back on. Somehow, is this a thing?
Yeah, that's a routine procedure. So if you have atrial fibrillation, which is one of the most common arrhythmias in our population, then basically every day we do here so-called electric cardioversion. An electric cardioversion is a synchronized electric shock done by the pedals. You just must sedate the patient because it's painful. So you sedate the patient for a short period of time, and during the anesthesia, you just give the heart a shock, and really the heart will restart. Yeah. So you will basically restart the heart. Fortunately for us, it's super rare that you will give the shock and there will be more severe arrhythmia or cardiac arrest.
You said it's 90% effective.
Yeah. So and it's very safe. Yeah. So the effect, the immediate effect of cardioversion is high. As you said, it's well over 70%. It's almost 90%. If you improve it with medical drugs, it can get to such a high number of success. However, this is a short-term result, and the long-term fight is a different issue because, for example, as you mentioned, your
He's got to stop drinking.
Yeah. Very good. Yeah. This is my first advice when I see patients with atrial fibrillation. There is Professor Vobosnikin. I think he's living in Australia. I don't know him, but he did with his team a very beautiful study. It was published in the New England Journal of Medicine, and they randomized patients to two arms. The first was like a controlled quit of alcohol consumption. No alcohol consumption versus just routine care. And there was a real difference in the occurrence of atrial fibrillation. If you stop drinking alcohol and if you already have atrial fibrillation, you will really lower the rate of recurrence. And the power of such intervention was almost as large as the medical intervention for the atrial fibrillation. So currently the state-of-the-art intervention is so-called ablation procedure, which is that we have to go through your vein to the heart. We have to find the source of the arrhythmia and put there a catheter and try to get rid of it. But again, we are trying to fix some scar in the heart, but the story is how the scar develops.
Sure.
And what you should do to stop it. Yeah, it's not the catheter. It's your lifestyle. You should stop smoking. You should quit drinking alcohol. You should start to regular physical exercise. This is the story. It's not about the catheter.
Yeah, being healthy is not fun and sometimes boring. Unfortunately, all the fun in life can be quite bad for our heart.
Yeah, and on the other side, if you want to hear more stories, I have patients who experience cardiac arrest and they do not quit smoking. So, and they experienced the second cardiac arrest and they survived. So they were so lucky. They survived 2 episodes of cardiac arrest, which is like a real blast. Like you survive 2 times. It's incredible. Yeah, but they still not quit.
It's not logic.
Yeah.
So if that doesn't scare them, then I don't know what does.
Humans are emotional beings, and that emotions are not logical a lot of the time. Wow, thank you so much. That's really great. So stop smoking, stop drinking, take care of your mind, take care of your body, and you don't have to get your heart burned.
No, but you should
What
also...
about sex? Is sex good for you?
Oh,
Is sex good for the heart, or does it also depend?
Like generally, you should enjoy your life. It's not about like, oh, you should always like keep aware of what you eat and no alcohol at all. I don't believe in it. You should enjoy your life. I was lucky that I had a teacher during my medical studies, Professor Koutecký. And Professor Koutecký was a founder of pediatrics oncology in the Czech Republic. He's a very well known, famous person. Unfortunately, he died years ago. At age 8, he was 88 years old when he passed away. And he had a heart attack when he was 45. So he was working hard. I think he was a smoker. And it was decades ago. So the only treatment was aspirin plus take a rest. And when he talked to me and he mentioned it many times, in Czech it's všeho s mírou, and it can be translated like
everything in moderation.
Yeah, too much of everything is harmful. Yeah. So if you do something which is not completely healthy for your body, keep it in some like low to moderate level.
Yeah.
And be aware of it that you should keep it low. But once you go for extremes, and it can be physical exercise, it can be work, it can be smoking. Once you get into these extremes, then it's dangerous for your body.
That goes right against my young philosophy. If a lot is good, then more is better.
Yeah, my dad had a heart attack at 48 when we moved to Canada, but he was working 3 jobs, and he was not sleeping, right? He was just grinding, and he was not drinking or smoking. He never has really. It was just the stress that got to him.
I think that Professor Koutecký, when he was 45, the only thing he did was just work. He was working so hard to take care of the kids, and then he must stop after the heart attack. And then he realized that he must find a balance. Yeah. But this is, I would say, a life wisdom. Yeah? I'm struggling to find the right balance in my life. Yeah? But
it's interesting that the people who talk about balance are the ones that usually burn themselves out in the past.
Well, you talk about a line that you've seen. If you haven't seen it, what is there to talk about? Right. That's the assumption is we get a little wiser as we get older, but it is an assumption.
Yeah, and you are completely right. You have to hit the wall, and then you realize there is some balance.
Or you can, I try to share some words of wisdom with people, but especially young people, I'm like, when I'm speaking to them, I realize I kind of want you to make your own mistakes, because it's like, what story are you going to have to tell? Like, if you just learn from everybody else's and you stay in this perfect bubble, then maybe just don't repeat them, right? Yeah. I tried to learn from my father's mistake of working too much, or I still work, I would say, a lot, but I tried to catch up. I tried to get my sleep. He managed to make some changes, and he's doing all right, but
we didn't answer the only question. Sex is good for us, right?
Yeah.
Please say yes, Dr. Rob. Please say yes.
Can you give us a prescription for both men and women? What is the right amount of sex according to a cardiologist?
Again, it's individual. It's dose dependent, definitely. And
our wives need specific numbers.
But don't be worried to ask your family physician or cardiologist. Yeah, and I always, don't be afraid to ask me. Tell my patients, even after heart attack, don't be afraid to ask me about this stuff. It's important for your life. So even after heart attack, you can live a very active life in this way. And there are, I think, no good studies on this topic. So I cannot comment.
Thank you for your time, and thank you for being you.
All right. Thanks.
Thank you.